"You're just the nurse. Could you get Dr. Bennett?" The young surgical resident didn't look up from the chart when he said it. I was standing 3 feet from him in the recovery unit, still wearing the navy scrubs I'd been in since before sunrise. The patient between us had just undergone major abdominal surgery. Her blood pressure was drifting downward, her heart rate was climbing, and there was something about the color of the fluid appearing in her surgical drain that I didn't like. I had already asked him twice to reassess her. This time he sighed. "She's post-operative," he said. "Some fluctuation is normal." I looked at the monitor, then at the patient, then back at him. "Call Dr. Bennett now." "That finally made him look at me," I said. "I heard what you said." Within 40 minutes, the patient was back in an operating theater with post-operative bleeding. She survived. The resident never called me just the nurse again, but that wasn't the moment that stayed with me. The moment that stayed with me came almost 2 years later, when I walked into a hospital conference room and found 16 newly appointed surgical trainees sitting behind desks. The director of surgical education handed me the first slide deck and said, "They're yours for the next 6 weeks." 2 of those trainees had heard the story about me. One had been in the recovery unit the morning it happened. And before I could teach any of them, I had to decide what exactly I wanted them to learn. My name is Evelyn Carter. I'm a registered nurse, and for most of my career I've worked in perioperative and surgical care. I am not a surgeon. I have never wanted to be one. I don't diagnose independently outside my scope. I don't perform operations, and I don't confuse experience with authority I haven't earned. But after 22 years around operating theaters, recovery units, surgical wards, and deteriorating post-operative patients, there are things I can recognize before someone with significantly more letters after their name has learned to recognize them. It took me a long time to say that without feeling as if I were boasting. Part of the reason was my family. My older brother, Michael, became a doctor. From the moment he entered medical school, my extended family seemed to decide that medicine had a hierarchy and that our places in it could be ranked accordingly. Michael was the doctor. I was the nurse. That difference was factual. The meaning people attached to it wasn't. At family dinners, relatives asked Michael about difficult cases and career progression. They asked me whether I was still helping out in surgery. When Michael became a registrar, my aunt raised a glass at Christmas and said, "At least one Carter finally made it all the way." The table laughed. I did too. I was 27, and I had already worked through night shifts, cardiac arrests, surgical complications, grieving families, and more bodily fluids than my aunt would have believed possible. But I laughed. That's something I've thought about over the years. Humiliation doesn't always arrive as open cruelty. Sometimes it arrives as a joke everyone expects you to help them enjoy. Michael didn't laugh that night. He looked at me, then at our aunt. "Evelyn is qualified," he said. "Oh, you know what I mean." "Actually, I don't." That ended the conversation. Michael and I had our problems, but that wasn't one of them. He knew what nurses did. The harder dismissals came at work. Most doctors I've worked with have treated nurses as colleagues. I want that said clearly. Hospitals function because different professionals bring different expertise, and good doctors understand that very early. Some don't. I learned this during my first year on a general surgical ward. I was 23, newly qualified, terrified of missing something and compensating by checking everything twice. One night, I was caring for a man who had undergone bowel surgery 2 days earlier. His observations were technically still within acceptable ranges, but something was wrong. He was quieter. His respiratory rate had increased. His abdomen looked slightly more distended than earlier. When I raised it with the junior doctor, I explained badly. "He just doesn't look right." The doctor looked at the chart. "Observations are fine." "I know." "So what specifically are you concerned about?" I couldn't articulate it. That was my failure, not his. I knew what I'd observed, but I hadn't yet learned how to convert nursing instinct into clinically useful communication. The patient deteriorated several hours later. He developed sepsis from an anastomotic leak and required emergency surgery. He survived, but barely. I went home the next morning and cried in the shower because I kept thinking about the hours between noticing something and being able to make anyone else understand what I'd noticed. For several weeks, I considered leaving surgical nursing. Instead, I became obsessive about learning. Not about becoming a doctor, about becoming a better nurse. I learned physiology beyond what my examinations required. I learned why trends mattered more than isolated numbers. I learned post-operative complications until I could connect subtle changes to specific possibilities without overstepping my professional boundaries. Most importantly, I learned how to communicate concern. Years later, hospitals would formalize many of those concepts through structured escalation tools. At the time, an experienced charge nurse named Margaret Doyle taught me a version in approximately 30 seconds. "Don't tell them you've got a feeling," she said, "but sometimes I do. So translate it. What changed? When? Compared with what? What are you asking them to do?" She tapped the observation chart. "Your instinct gets your attention. Evidence gets theirs." Margaret was formidable. She was also right. I stayed. I moved into high-dependency surgical care, then theaters, then post-anesthesia recovery. I completed additional specialist training. I became the nurse people called when a new staff member needed help with a complex post-operative patient, or when a handover didn't quite add up. And I made mistakes. Once, during an exceptionally busy recovery shift, I focused so heavily on a patient's respiratory status that I failed to notice a medication chart discrepancy quickly enough. Another nurse caught it before the medication was administered. I was humiliated, not publicly. Internally. I had built so much of my identity around noticing what other people missed, that being the person who missed something frightened me. Margaret found me rewriting the incident report after shift. "How many times are you going to rewrite that, until it stops sounding stupid? You made an error." I nearly made an error, and someone else caught it. That's the system working. It doesn't feel like it. It isn't supposed to feel nice. She sat beside me. "Experience isn't becoming incapable of mistakes, Evie. It's becoming difficult to teach if you start believing you are." I kept that too. By my 40s, I was a senior clinical nurse specialist in perioperative care at St. Catherine's University Hospital. My role included staff education, quality improvement, and direct clinical support. I still spent substantial time with patients because I refused positions that would have removed me from bedside work entirely. There is a particular kind of knowledge you lose when your only contact with clinical care becomes meetings about clinical care. I didn't want to lose it. The incident with the resident happened during a winter that tested almost everyone in our department. His name was Dr. Nathan Cole. Nathan wasn't incompetent. That's important. He was intelligent, technically promising, and exhausted. He was also in that dangerous stage of medical training where someone has learned enough to feel confident, but hasn't yet accumulated enough experience to understand how unreliable confidence can be. The patient was a 58-year-old woman named Mrs. Alvarez, who had undergone a complex abdominal procedure. Initially, her recovery was appropriate. Then her blood pressure began drifting, not crashing, drifting. Her heart rate increased. The drain output changed. Her skin became cool. I reviewed the trend, checked the drain, reassessed her, and asked Nathan to come. He reviewed the monitor and post-operative orders. She had a major operation. I know. Her pressure isn't terrible, not yet. He ordered fluids and left. For a short period, her pressure improved. Then it fell again. This time her pulse climbed further. I called him back. He arrived irritated. I understand some of that irritation now. The surgical service was stretched. He was covering multiple patients. Every call forced him to reprioritize. But none of that changed the patient in front of us. "We need Bennett," I said. Dr. Laura Bennett was the consultant surgeon responsible for the case. Nathan looked at me. "I've assessed her. She needs senior review. You're just the nurse. Could you get Dr. Bennett and let me manage the patient?" The room went very quiet. One of our junior nurses stopped writing. I remember feeling heat rise into my face, not because he called me a nurse. I am a nurse, because of the word just. 20 years of work reduced to 4 letters placed before my profession. For perhaps 2 seconds I wanted to respond to the insult. Then Mrs. Alvarez moved slightly and made a sound, and the argument became irrelevant. I used our escalation pathway and contacted Dr. Bennett directly. She arrived within minutes. I gave her the sequence. Pressure trending down despite initial fluid response, tachycardia worsening, drain output increasing and more sanguineous. She's cooler than 30 minutes ago. Dr. Bennett examined the patient. Her expression changed. She ordered urgent blood tests and resuscitation measures while arrangements were made for rapid imaging versus return to theater, depending on stability. Mrs. Alvarez deteriorated further. The decision was made to return directly to theater. I didn't operate. Nathan didn't operate independently either. Dr. Bennett led the surgical team. They found significant post-operative bleeding and controlled it. Mrs. Alvarez required transfusion and spent time in critical care. She recovered. There was no dramatic hallway confrontation afterward. There was a clinical review. Nathan's delayed escalation was discussed. So was communication between disciplines. So was the fact that the hospital had a culture problem that couldn't be explained by one tired resident saying one arrogant sentence. Dr. Bennett asked me into her office several days later. "You were right," she said. "I was worried. You escalated appropriately." I nodded. Then she surprised me. "Would you be willing to present the case at morbidity and mortality?" My first instinct was no. Those meetings were full of surgeons, anesthetists, and senior clinicians. I had attended them. I had contributed occasionally. Presenting a case involving a doctor's failure to take nursing concerns seriously felt like walking voluntarily into a room with petrol and asking who had a match. "I don't want this to become about Nathan," I said. "Neither do I. He made a poor decision." "Yes. But if we turn him into the villain, everyone else gets to leave believing the system is fine." Dr. Bennett leaned back. "That's exactly why I want you presenting." So I agreed. Nathan was there. I stood in front of the room with Mrs. Alvarez's observation trends on the screen. I did not mention just the nurse. I did not need to. I showed what had changed physiologically. I showed when concern had been escalated. I showed where communication failed. Then I showed something more uncomfortable. 2 previous cases from our department where nursing concerns had been documented before medical escalation occurred. Nobody had died in either case. That wasn't the point. "What would you change?" one consultant asked. "Teach escalation as a team skill," I said. "Not something junior staff do upward when senior staff permit it." Another surgeon asked. "Meaning?" "Meaning residents need to learn what experienced nurses are seeing, and nurses need to communicate that information in a format residents can act on." Both sides. Nathan spoke for the first time. I dismissed information because of who it came from. The room went still. He didn't look at me. "I thought I had assessed the patient, therefore the assessment was finished," Dr. Bennett asked. "And now?" Nathan looked at the slide. "Now I think assessment is something the team keeps doing." It was the most useful thing he could have said. After the meeting, he found me near the lifts. "I'm sorry." I waited. "Not just for the wording," he said, "for not listening." "Thank you. I've thought about it a lot." "Good." That surprised him. I almost smiled. "Feeling terrible forever isn't useful, Nathan. Learning something is." That could have been the end. It wasn't. Over the following year, St. Catherine's underwent a broader review of surgical training after feedback from trainees, nurses, and patient safety committees. One recurring problem was transition. New surgical residents arrived with excellent theoretical knowledge and varying amounts of practical experience, then entered an environment where they suddenly had to recognize deterioration, communicate across professions, prioritize multiple patients, and understand postoperative care at speed. The Director of Surgical Education, Dr. Samuel Okafor, asked me to join a working group. I expected meetings. I got meetings. So many meetings. But something useful came out of them. We designed a perioperative safety program for incoming surgical trainees. Not a program teaching them surgery. That distinction mattered. Consultant surgeons would teach operative decision-making and technical skills. Anesthetists would teach airway and perioperative physiology. Pharmacists would cover high-risk medication processes. My section was postoperative recognition and interdisciplinary escalation. I built it with 2 nurses, an intensivist, a surgical consultant, and a simulation educator. We used realistic scenarios, a patient whose numbers were individually acceptable but whose trend showed deterioration, a postoperative patient becoming confused before becoming hypotensive, a nurse with 6 years of experience raising a concern to a resident who was distracted by another emergency, a junior nurse communicating poorly but correctly identifying that something had changed. The residents weren't graded on whether they obeyed the nurse. I hated that framing. They were assessed on whether they could gather useful information regardless of the speaker's position, make safe decisions, escalate appropriately, and treat colleagues as sources of clinical data rather than pieces of a hierarchy. The pilot went well enough that the hospital expanded it. Then Dr. Okafor came to my office. "We want you to lead the induction block next August." "For nurses? Surgeons?" I laughed. He didn't. "Sam." I'm serious. I'm a nurse. Yes, Evelyn, we noticed. Evelyn, we noticed. I'm not teaching surgery. Nobody's asking you to. He placed a folder on my desk. We are asking you to train new surgical residents in the part of surgical care you've spent 22 years doing. I looked at the folder. There was something almost absurd about it. Not because nurses don't teach doctors. They do, formally and informally, in hospitals everywhere. But because I remembered being 23 and unable to convince a junior doctor that a patient looked wrong. I remembered family dinners. At least one Carter made it all the way. And I remembered Nathan, just the nurse. What if they resent it? I asked. Some might. Helpful. I'm not hiring you to be popular. I looked at him. 6 weeks? 6 weeks. So I said yes. The first morning, 16 trainees sat in the education center. Nathan was there, but not as a trainee. He had volunteered as a simulation facilitator. That mattered to me more than his apology had. I introduced myself. I'm Evelyn Carter. I'm a perioperative clinical nurse specialist. For the next 6 weeks, I'm going to teach you about post-operative deterioration, escalation, and the clinical information your colleagues at the bedside may see before you do. One trainee raised his hand. Are we being assessed? Yes. The atmosphere changed immediately. On what? Judgment, communication, recognition, knowing when you need help. A few people smiled. I added, and if anyone is hoping there's a station where you prove you're the smartest person in the room, I'm afraid we couldn't get funding for it. They laughed. Tension broke. Then we worked. In week 2, one simulation recreated parts of Mrs. Alvarez's deterioration, with enough details changed to protect confidentiality. A trainee named Sophie noticed the trend quickly. Another trainee focused on the normal blood pressure reading and dismissed her concern. The scenario progressed. The simulated patient deteriorated. We stopped. What happened? I asked. The second trainee sighed. I anchored on one number. Why? Because it reassured me. And what information did you have that wasn't reassuring? He looked toward Sophie. Heart rate, drain output, skin temperature, trend. And, he hesitated, Sophie told me. Miss, I didn't humiliate him. That would have defeated the entire purpose. We reset the scenario. He did it better. That was the work, not revenge. Correction. 3 months after the program ended, I was walking through the surgical ward when someone called my name, Mrs. Alvarez. She was there visiting another patient. It took me a second to recognize her because the last time I had seen her she had been pale, exhausted and surrounded by monitors. She hugged me before I could decide whether we were hugging. My daughter told me what happened, she said. Your clinical team did a lot. She said you wouldn't stop calling people. I laughed. That's a slightly dramatic version. I like her version. We talked briefly. Before she left, she said, I'm glad you were there. That sentence meant more to me than being asked to train surgeons. Because education programs are important, titles are nice, recognition can correct something old inside you, but patients are the point. Nathan completed his training and eventually moved to another hospital. Before leaving, he gave me a card. Inside he wrote, "Thank you for teaching me to listen before I had enough experience to understand why I needed to." I keep it in my desk, not as a trophy, as evidence that people can change. My brother Michael found out about the surgical training program through my mother. He called me immediately. So apparently you're training surgeons now. I'm teaching part of their induction. That's not how Mum tells it. How does Mum tell it? Apparently the hospital finally realized you've been running the place for 20 years. I laughed. Then he became quiet. Do you remember what Aunt Patricia said that Christmas? Unfortunately, I should have shut it down harder. You did fine. No, I corrected the fact. I didn't correct the attitude. That was an interesting distinction. I told him the truth. It bothered me for a long time. I know, but I don't need you to fix 27-year-old me. Good, because I'm about 15 years late. 17. See, nurse, terrifying attention to detail. Some family habits improve more quickly than others. I still work at St. Catherine's. I still wear scrubs. I still have mornings when a consultant disagrees with me and is correct, because experience does not make me infallible. I still ask junior nurses to explain what they're seeing, instead of accepting, I just have a feeling, because Margaret Doyle's voice lives permanently somewhere in my professional brain, and every August, a new group of surgical trainees arrives. Some are confident, some are frightened and hiding it, some have never worked closely with experienced nurses. By the end of the first session, I tell them one thing: nobody in this hospital is just anything. Not because every role is interchangeable, it isn't. A nurse cannot substitute for a surgeon. A surgeon cannot substitute for a nurse. Different professions have different training, responsibility, and scope, and pretending otherwise is not respect, it's confusion. Respect is knowing the difference without turning difference into a ranking of human worth or useful information. I learned that the hard way, so did Nathan, and somewhere between a post-operative patient whose changing observations were almost dismissed, and a classroom full of new surgeons learning how not to make the same mistake, the phrase that once made me feel small stopped having any power over me. They called me just a nurse. I never needed to become anything else to prove them wrong.